All right, so tonight we're going to cover neurologic emergencies. All right, so stroke is the fifth leading cause of death and the leading cause of adult disability in the United States. This is according to the American Stroke Association. So it's common in geriatric patients, and the contributing factors for stroke include family history and race. There are new treatments are available for stroke, and again, we'll get more of that a little bit into the presentation under neuro. However, we're starting to see more telestroke conferencing with patients. We're seeing longer times where they can be having a stroke, where we can start TPA at the hospitals or thrombolytics. And again, we're starting to see a lot of these things evolve. And with that being said, we are seeing some of these newer treatments that are there. Also, rapid recognition in the field. Seizures and altered mental status may also occur when there is a disorder of the brain. Seizures may occur as a result of like a recent or prior head injury, so any kind of fall, a brain tumor, metabolic issues. One of the big ones with the metabolic issues would be like low sodium, and that can cause seizures as well. Fever, obviously, and it could be febrile seizures, where we have that rapid rise in temperature. And then the body says, wait a minute, we need to start seizing. This is more in the pediatric realm to cool the body back down. Or a genetic disposition like chronic seizures and chronic seizure history. Some possible causes of altered mental status include intoxication, head injury, hypoxia, stroke, and metabolic disturbances. So treatment varies widely as far as what we're going to do. I mean, obviously, with intoxication, there's not a lot we can do. As you move into ALS levels, we're looking at, again, I'm going to keep it more towards the states that are here. And IV fluids, cardiac monitor, things like that to help. But again, we're not going to be doing any like vitamin B or thiamine administration. So that's something that we carry normally in most states. Obviously, with head trauma, head injuries, we really need to be monitoring that end-tidal CO2 monitoring for these patients. There are other things we can look at for head injuries as well to kind of see things. But again, this is more towards the advanced critical care level, paramedic level stuff. Hypoxia, obviously looking at your pulse oximetries, but also looking at the actual patient and looking for a cyanosis. Stroke, deficit, things like that, disturbances metabolically. One of the big ones usually is sodium levels dropping too low. So again, treatments, they varies widely as far as how we're going to be administering cares. Well, a quick A&P. So anatomy and physiology. Remember, the brain is the body's computer. That is what's going on. It controls the breathing, the speech, and all the other bodily functions. There are three major parts. There's a brainstem, the cerebellum, and the cerebrum. And the cerebrum is the largest part. So let's go here to the next slide. You kind of see where this stuff is. The cerebrum being this massive area. One of these days, so all this right here, that's the cerebrum. That's a massive part of the brain, right? The cerebellum being here, and then you see the brainstem right there. Obviously, the skull here. Remember, there's no give to the skull. We'll cover more about that when we get into head bleeds. Remember, the brain is well protected with the skull. That's why the brain is so well protected. The brain's major parts, we talked about those already. The big part, remember, though, is this is all fluid. There's fluid around it. The brain, as a part of that cushion of protection, right? All the different matters that are up there, the dura matter, the pia matter, things like that are up in the brain. And what it does is, though, you got to look out for specific types of injuries, and we'll get more to that later. But again, think of a walnut sitting in a bottle of water. Okay, that's kind of what our brain is, and our brain's kind of just sitting, in a container, a closed container, with a hard surface that has no give, unless there's actually a fracture or things like that. So again, we'll cover more of that when we get into the more of the head trauma stuff. So the brainstem controls the most basic functions: breathing, blood pressure, swallowing, pupil constriction, or the cerebellum controls muscle and body coordination. Okay. The cerebrum, located above the cerebellum, is divided into a right and left hemisphere. Okay, that's going to be important for us to pick up on, because if I draw a skull like this, okay, we have the midline go straight down. Then we have the two hemispheres here, one in here, and the other side being there. All right. So the front of the cerebrum controls emotion and thought. So up here, so let's say this is the top here. I'll put an F the best I possibly can. All right, so it's the front, and this is the rear back there. All right. So again, this front part up here, I'll put little X's in there. Right. So that's controlling the emotions and thought. The middle parts, so if I draw another line here, I'll put two X's here. These are our middle sections. The middle parts control sensation and movement. And the back side of the head controls sight. Right. So we got to make sure that we're looking at all of these here when we're doing our assessments. Right. So if we think about that occipital region being back here, and our frontal region being up here. Right. So in most people, speech is controlled on the left side of the brain near the middle of the cerebrum. Okay, so left side, so the middle. So I'll draw that brain again up here. Right. Draw a line down the midline here. We have our front sections, middle sections, rear sections. All right. So the left side of the brain, looking at the brain, remember, top, bottom here, front, the left side. This is going to control our speech at that point. Right. So messages sent to and from the brain travel through the nerves, and there are 12 cranial nerves that run directly from the brain to parts of the head. Right. And one of the biggest nerves that we talk about is I'll put it X here, the 10th cranial nerve. Right. And that's our vagus nerve. And that's one of the ones that can be stimulated quite often on things that we do or bearing down. And that's one of the biggest nerves we need to remember is that 10th cranial nerve being that the vagus nerve. Right. The rest of the nerves join in the spinal cord and exit the brain through the large opening in the base of the skull. That's called the foramen magnum. Right. So at each vertebrae in the neck and back, two nerves branch out from the spinal cord and carry signals to form the spinal cord itself. And I can show you that here in the next slide. Right. So you can see the nerve endings coming off here. All right. So you have nerve endings there. Remember that the spinal cord is a continuation of the brainstem. It exits from the skull at the foramen magnum. So the foramen magnum being up here, there's a big opening up here. And it goes straight down through. And you can see all the nerve endings coming off the spinal cord. Okay, these are all spinal nerves. All right, they extend down to the level of the second lumbar vertebrae. Okay, so lumbar down here. Then our sacral being down lower. We have 33 vertebrae total. This is not a trauma class, but we'll go over that really quick. There's 33. There's 7 cervical. There's 12 thoracic. Right? We go down here to 12 thoracics down here. Then we have 5 the lumbar, and then we have the sacral, 5 here, and then we have 4 way down at the bottom, and that's your coccyx. Right? And that'll equal 33 total vertebrae. What we really need to pay attention to, though, obviously, is brainstem injuries, or I should say spinal cord injuries here, and looking at where the injuries potentially could be, causing paralysis from that point down, right? There's 2 locations to kind of keep in mind when we start talking about dermatomes, and we'll get into dermatomes here in a little bit. And with the dermatomes, we look for T4 and T10. It kind of gives us an idea of where paralysis can start. And T4 will be the nipple line, and T10 is right the umbilical line. All right, so it's a little about patho. There are many different disorders that may cause the brain dysfunction and may also take effect in the patient's level of consciousness, speech, and voluntary muscle control. So the brain is the most sensitive to changes in oxygen, glucose, and temperature levels. A significant change in any one of these resulting in neurological change. So if you think about it, if we have hypoglycemia, the patients may become altered, right? If we become hypoxic, they become altered. If they are hypothermic, they can become altered. Same thing if they become hyperthermic, right? So the brain needs these things. It needs that sugar. It needs that oxygen. It needs the blood to function, to stay alive, right? That's why it's so important that we take a look at that. All right. So one of the most common complaints is a headache. I apologize for the slide. I'm not sure why that slid that direction. Um, this can be a symptom of another condition or a neurological condition of its own, right? A small percentage of headaches are caused by a serious medical condition, right? And tension headaches, migraines, and sinus headaches are the most common types of headaches, right? Especially the migraine ones. We talk about migraine. And again, there are some things out there where they say sodium levels could be off. It could be that you need some more sodium in your system. To caffeine works really well to help vasodilate, and then the sodium helps push the salt out of the cells and reduce. It also helps in reduction of swelling. So therefore, your migraines can probably be more subsided. There's some other things that are out there too, as far as looking at the headaches and the serious medical conditions would be your head bleeds, right? And some of the head bleeds we can see would be like an epidural bleed, a subdural, subarachnoid, things like that. We'll get into more of those in a little bit. So tension headaches are caused by a muscle contraction in the head and neck that are attributed to stress. So the more stressed you are, you start building that tension, your muscles are tense in your neck, and then it starts giving you headaches. All right, the pain is usually described as a squeezing, dull, or as an ache, and usually do not require medical attention. Migraine headaches are thought to be the cause of changes in blood vessel size at the base of the brain, right? So we talked about, again, if we can increase more blood flow, a lot of times those migraines can go away, right? So we talked about, that's why I mentioned caffeine. I'm not saying that's what you do for your patients, okay? That's not a patient treatment. But again, if you have your own migraines, try some caffeine and some sodium and see what happens with that. The pain is usually described as a pounding, throbbing, and pulsating, often associated with nausea and vomiting, and may also be preceded by visual warning signs such as flashing lights or partial vision loss. Migraine headaches can last several hours to days. All right, sinus headaches are caused by pressure that is a result of fluid accumulation in the sinus cavities. So patients may also have cold-like symptoms or cold-like signs and symptoms of nasal congestion, cough, and fever. So pre-hospital emergency care is not required. Let me go back one slide, though. Migraines may require emergency care. There are some medications that we're not going to be administering other than Tylenol for pain, right? Or if you have IV Tylenol, looking at other states, have IV Tylenol for the advanced EMT or paramedic level for pain management. It works great, but again, it's a temporary fix to the bigger problem, what's going on, right? Remember before we talked about, the changes in blood vessel size in the base of the brain. Right. So we got to really look at that, those headaches, those migraines. So they can become a critical, I was like critical. They can become a patient. They may need to go to the ER to other medications. I've seen Haldol administered before for migraine headaches and things like that. It's kind of relaxing the body as that sedative to kind of relax yourself. Those things do help as well. So again, patients that have migraines all the time will probably be on medications to kind of help with that. And we already went over sinus headaches. So again, serious conditions that include headache as a symptom are hemorrhagic strokes, so the brain bleed, the head bleed, brain tumors, and meningitis. All right. So let's get into here. Stroke, or a CVA, cerebral vascular accident, is a interpretation of blood flow, interruption of blood flow to an area within the brain that results in a loss of brain function. So that clot moves, okay, and from somewhere into the brain, causing it to block off the artery and not providing blood to the rest of the part of that brain where that artery would flow. Okay, so again, we need these are critical patients. These are sick patients that have a time frame. right? There are two major types of strokes. Again, we'll go back into the ischemic stuff, but there's ischemic stroke, there's hemorrhagic stroke. Ischemic, remember, that being that clot, the one that shuts down the brain, right? It shuts down those vessels. Whereas a hemorrhagic stroke is actually the bleed, okay? They're both still considered sick patients, but head bleeds can progress very quickly depending on where it is, right? Like an epidural bleed would most likely be the middle meningeal artery. Think of MMA fighting, right? Kick to the head causes an epidural bleed, right? The middle meningeal artery, right? Then we have our subdurals, obviously below the dura versus epidural being above. Again, it's all depending on where you see. I'm not sure if we have any, maybe one coming up here in a little bit. I can kind of show you what it looks like. I can draw it out. There's a head coming up here. So I can show you guys the differences between the subdural and epidural bleeds. And then obviously I'll show you where the subarachnoid bleed would be located in the head. All right, so the ischemic stroke is the most common, accounted for 87% of strokes. Results from a thrombus or a thrombosis or an embolus. Symptoms can range from nothing at all to complete paralysis. All right. So again, plaque buildup, okay? Plaque buildup in the blood vessels are obviously a common cause, having that clot or something like that breaking free and causing that ischemic stroke or that dying tissue, as you can see here. And I'll kind of draw some things up in this one as well. But again, you have your arteries coming in, okay? And this is where your clot is located. Then you start having that tissue death underneath it. And that's where we're going to start seeing slurred speech, facial droop, arm drift, again, unequal grips, things like that. We're going to start seeing a lot of these different signs and symptoms. Okay, again, the facial droop, difference in sensation on both sides. So we're going to start looking for those unequal pupils, right? We're looking for all those different signs and symptoms. We need to do our tests, whether it be the RACE score, the NIH, LA stroke scale, to Cincinnati stroke scale, to whatever one you're using, and what your services require to use or state requires you to use. That's what we need to be following. Okay. The hospitals use what they call an NIH score, and that goes up to like 24. There's a lot of different numbers in between those. So you can, again, it's a longer assessment. And that's what they're going to be utilizing along with CTs to figure out where they sit on that score and whether or not they're going to become a TPA candidate. Right. And it's all based on timing. One of the things we really need to pay attention to, especially in the ischemic or hemorrhagic strokes, again, is the last time seen normal. So when we do our assessment, when were they last seen normal? Was it before they went to bed, right? Did it happen an hour ago where they started seeing any kind of changes? And I'm talking about as simple as I have numbness on one side of my face versus the other. And that's when symptoms truly start. So we have to ask those questions. Or again, on the hemorrhagic side of things, right? I've been in nursing homes before where I've seen unconscious patients due to a head bleed. And you asked the question, were there any recent falls? They said, yeah, they fell a week ago and they are on blood thinners. We sent them to the hospital and they didn't find any bleeds, any head bleed. Okay. Again, they still need to be monitored because even as smallest of bleeds, you might not be able to pick up on a head CT. It's so small. But again, over a week's period of time, that's when things start to happen. Then a week later, they go into the room and the patient's unconscious. Well, I'm not sure why they're unconscious. Well, they fell a week ago. They're on blood thinners. There possibly could be a head bleed causing that unconsciousness, right? So going back to the other types of bleeds, right? So there's two different types. There's, well, three, right? The first one we're talking about is the epidural. So the epidural, I'm trying my best to draw this out here with a pen, right? You're going to see pressure like this in blood. So you'll see that concave, but this section here, right? This would be your epidural bleed, okay? Bleed in the located here above the matter, the dura mater here, and it pushes down against the brain that direction, right? Causing significant bleeding, but pressure. It hasn't broken through that dura mater yet. If you have a, let me erase this really quick. There's not really a lot of space to draw this out. All right, erase. If we look at our subdural, and that's gonna be like our moon shape, right? Remember, it's below the dura mater. So if I draw a line here, being the dura mater, right, then we start having that bleed. It looks like this, kind of like that. And what it's doing is it's pushing in that direction, okay? Causing, let's say, the midline being straight up and down here. That's kind of horrible. It's between the drawing a blank for a minute here. Wow. All right. So we look at the midline here. We start seeing that push. These are ventricles. That's what I was looking for, the word. I knew it would come up to me eventually. Our ventricles are here. So we're having push. And if this midline starts shifting this direction, if you're looking at a head CT, what you're going to see is these ventricles will be over here instead. Okay? Because again, there's so much pressure on that subdural or even a subarachnoid bleed, which would be located in the arachnoid matter. So basically down in this area, or same thing on this side over here. Again, it's taking that pressure and pushing. And the more you push, the more altered they can become to the point where your brainstem sitting back here, right, can herniate, causing significant issues, right? You talk about brainstem herniation, the loss of breathing. This is why patients that have significant shift, midline shift, with a significant head bleed, whether it be a subdural or a subarachnoid bleed, they're getting intubated to protect that airway. Because again, if that shifts enough and we have brainstem herniation because of all the blood that's inside here and it herniates over, at that point in time, they lose that ability to breathe. They lose that ability to keep the airway patent and open. So we have to protect that kind of stuff. Other things you're going to see too, especially with the head bleed. Again, let's go to the next slide here really quick, and here it is. Right, you talk about the hemorrhagic stroke. Is you're going to have the worst headache of your life. If they say, "I've never had a headache this bad, ever, ever, ever. This is the worst one I've ever had in my life." Where does it hurt? And they point to their forehead. Right? It hurts right here, that one spot. Most of the time, it's probably going to be a head bleed, especially if they have other symptoms going along with it as well. Right? So look for that hypertension. That's another key sign of this hemorrhagic stroke, right? If it's not non-traumatic, is the hypertension. I'm talking blood pressures 240 over 120. Look at those super high blood pressures for severe hypertension, right? Again, I also need to ask questions. Did there any recent falls? Are you on any blood thinners? These are important questions to make sure you're asking during your assessment, right? This accounts for 13% of strokes. One of the things I've also noticed in the hemorrhagic stroke as well, this is based upon my observations for all the years I've been doing this job, is they start doing a lip smacking. So they'll go like that. They start smacking their lips. They just don't make any sense. A lot of times when you see that, most likely it's going to be a head bleed. That's somewhere. Again, we're not going to diagnose where the bleed is located. They have to get a CT done. But again, we need to kind of have an idea. This potentially could be a bleed. We need to call this in as a stroke alert at the hospital so they can go right to CT. And that's the big important part, is calling that stroke alert early, so they know. Let's see. So cerebral hemorrhages are often fatal. Keep that in mind. The cerebral hemorrhage can be very fatal, especially when you start seeing midline shift and herniation. People at high risk include those experiencing stress or exertion. People at highest risk are those who have very high blood pressure or long-term elevated blood pressure that is not treated. So we got to make sure they're on these medications like lisinopril, metoprolol, losartan. All these different medications are out there for hypertension treatment. Hydrochlorothiazide being another one. And again, look at their medication list and say, are you being treated for this hypertension? Right. And if they say yes, and I'm compliant with the medication, and there's blood pressure that's still high, right? They need to get regulated. Again, we're not going to do the regulation, but they need to talk to their primary care. Okay. So they start to feel like they have a headache, they feel flushed. These are your hypertensive crisis patients that could turn into a hemorrhagic stroke. So we got to really pay attention to these patients when we're transporting them. All right. A Barry aneurysm is a common cause of hemorrhagic stroke in healthy young people. It presents as the worst headache of their life, as what we were talking about before here, as you can see in the bleed. And this causes a subarachnoid hemorrhage, right, in that subarachnoid space. So this is just kind of a picture of what the bleed would look like here under a CT. The CT, and you'll start seeing contrast, all that kind of stuff running through here, so you can see blood flow. So swelling or enlargement of the wall of an artery resulting from a defect or weakening of the arterial wall. So again, we have that bleed, that artery pops, so it's bleeding into the brain. So this is an angiogram, what they call our CTA, have a name for it, CT angiogram showing the cerebral hemorrhage, right? And the angiogram part of it is dye that's pushed in, and then they can see where the bleed is actually located. All right, a TIA is a transient ischemic attack. So again, stroke-like symptoms go away on their own in less than 24 hours. Right? There may be a warning sign of a larger stroke to come, and it's considered an emergency. So again, if they have had it, they have the symptoms like the slurred speech or some weakness or deficit on one side, and it goes away, they still need to be transported and have a CT done because there could have been a small clot somewhere in those arteries that freed up. But it doesn't mean that the next one is not going to be a full-blown stroke, right? So we need to make sure we convince these patients to go to the hospital. They need it. These are not patients that we do patient refusals. And if we are getting a refusal, it's against medical advice, and they need to be told that this could kill you, and you really should be going to the hospital. Right? About 1/3 of the patients who have TIAs will experience a stroke soon after, whether it be the same day, 24 hours later, or even 2 weeks later. All patients with a TIA should be evaluated by a physician. They need to go see a doctor. They're going to do the NIH stroke scale. They're going to get a head CT done. They're going to figure out what is going on for these patients. Signs and symptoms of a stroke. Obviously, general signs and symptoms include the following: facial drooping being one. That's also part of your Cincinnati stroke scale. Sudden weakness or numbness in the face, arm, legs, or on one side of the body. We look at our arm drift being number 2, right, of that. And then also decrease or absent movement or sensation on one side of the body, right? And the other part would be a lack of muscle coordination. That's called ataxia or a loss of balance. But our Cincinnati stroke scale has the 3 things, right? It has a slurred speech, facial droop, and your arm drift. Other things you can utilize is what they call a FAST ED, so FAST ED score. And you can actually download the app on your phone, and you can get a FAST ED score looking at different signs and symptoms that are there. And what would happen would be is it'll give you a score. And with that score also shows you, percentage of a large vessel occlusion or a small vessel occlusion. Again, nothing that you're going to do in the field. These patients need to get to a hospital. And it has to be a hospital or a stroke center. Right. The biggest thing is, do they carry, if it's a stroke center you're going to, right? I shouldn't say a stroke center, but like a critical access hospital. You got to make sure they have CT available and they have the ability to give a clot buster like TPA, right? If they can start that in the field, and that starts the treatment to at least get them to get a thrombectomy done at a bigger center, like a level 1 trauma center that has 24-hour neurosurgeons on staff for that. Let's see. So sudden vision loss in one eye, or blurred and or double vision, difficulty swallowing, speech disorders, right? Decreased level of responsiveness. These are all other signs and symptoms of a stroke. Right? Aphasia, which is difficulty expressing thoughts and the ability to use the right words. Expressive aphasia, or difficulty understanding spoken words, receptive aphasia. Right? So if you ask them, like, for example, say, what color is the sky? And they start saying, tacos, right? Again, expressive is more of your aphasia. That's their expressive aphasia, but they don't know what right words to speak, even though they know what they need to say. They just can't get those words out, right? Or they start having the receptive aphasia, and they have difficulty understanding spoken words. They're like, what are you looking at? They give you that weird look. Like, what are you talking about? Things they should know. Obviously, we have dysarthria. So dysarthria is slurred speech. Sudden or severe headaches, confusion or dizziness. Some other things as well. Weakness, combativeness. I've seen patients that have had head bleeds that are either unresponsive or they're very combative, right? Because again, remember, it changes our brain function when you start pushing pressure on certain aspects of the brain. It can change who we are. It can change how we feel. It can change moods, right? Tongue deviation is another one. Restlessness, coma. Right, so we got to look for all these different signs and symptoms of the stroke patient. All right, moving on to the left hemisphere. So stroke in the left cerebral hemisphere may cause aphasia. Aphasia, remember, is the inability to produce or understand speech. Right, so speech problems right there can vary widely. Right, so again, we talked about the brain. I'm horrible at drawing stuff, so don't judge me. right? We have our midline here, right? We have our different hemispheres, right? Our frontal lobe being up here, occipital, parietal, lobes on the side, right? Look at all the different lobes of the brain. When we're looking at this here, we're talking about, the speech section. Oh, sorry about that. On that whole left side, left hemisphere. Okay. So short-sighted affect the left side of the brain can also cause paralysis to the right side. So anything that happens on the left, right? Think of opposite what's going to happen. So if they have let's say they have left-sided bleed or a stroke, we're going to start seeing right-sided deficits on those. And then vice versa. Everything's opposite of where the bleed or potential occlusion could be. The right hemisphere, strokes that affect the right side of the brain can cause paralysis on the left side of the body. Usually patients will understand language and be able to speak, but their words may be slurred or hard to understand. Okay. Patients with may be oblivious to their problem. All right. This symptom is called neglect. Right. So they may neglect certain parts of their vision or neglect in lack of pain, which causes many patients to delay seeking help. They're like, well, I feel okay. They feel good. But again, we're seeing other things when we look at our assessment of that right hemisphere. So things to take home from that one there, right? Patients will understand language and be able to speak, but their words may be slurred or hard to understand versus, right, a left side where the patient, right, is aphasic. Okay. There we go. The bleeding in the brain. So patients may have very high blood pressure with these. We need to look for that. You get a good set of vital signs, right? This may be the cause of the bleed. It may not be a fall. It may not be traumatic. It could just be that a vessel popped because the blood pressure is way too high. Remember systolic and diastolic and how that works. Remember that your systolic pressure is pressure, I'm going to say in motion, but not at rest, right? So again, we have a lot of pressure in those vessels. The big concern is going to be is your diastolic pressure. That's your vessels at rest, right? We want that to be below what, 70, right? That's a number between 80 and 70. I think about 80, we start seeing that, borderline, here's your pre-hypertensive patient. And then if higher than 80, we should be a little concerned and why it's going up, right? So again, that's your arteries at rest versus arteries under pressure, right? And then we look at our mean arterial pressure as a whole, right? And remember, to calculate mean arterial pressure is you do 2 times the diastolic plus your systolic divided by 3. We give you your MAP, or mean arterial pressure. Right? And that's going to be important for us to know, especially with bleeding in the brain, to make sure that we're not, again, make sure it's not too high, but also not too low. We got to make sure that we treat this effectively. And one of the best ways to do this, honestly, one of the best ways to do this with a patient, whether you're interfacility transport or you're 911, right? If they are truly that sick, right, let's say their altered mental status is getting them intubated, and then we can control the vessels by looking at end-tidal CO2 monitoring, right? So again, we're looking at the vessels. Carbon dioxide is a very, very potent vasodilator. So with it, again, so if we have high numbers of carbon dioxide, let's say we know our normal values being 35 to 45, as we're going higher and higher, we're seeing more dilation and more dilation. And that can be controlled by just increasing the respiratory rate by breathing a little bit faster, getting our end tidal down to 30 to 35. If our end tidal is dropping below 30, now our vessels are constricting too much. And if we're constricting too much, yeah, we're slowing the bleed down. However, we're also not giving them the oxygen that they need. So the magic number is between 30 and 35 for an end tidal while you're ventilating your patient who you think has a head bleed, especially if they're unconscious. Now, I'm not saying EMTs go ahead and start intubating patients. That's not what I'm saying. Okay. But if you drop an NPA in place or an OPA and you're bagging the patient using a BVM, make sure that you also have end tidal running because you can look at that. You can see what they're off gassing, right? And that can help you understand, how acidic they are and looking to try to make our respiratory rate based on our end tidal between 30 and 35. There's no magic number, at all when it comes to figuring out what you need um, to help this patient at all, right? As far as how many breaths per minute you're going to be giving, what we're looking for really is looking at that end tidal number between 30 and 35 to kind of make sure that we're not really too fast or too slow, not either giving them lack of oxygen or giving them too much blood to the brain. Right, conditions that may mimic a stroke are obviously hypoglycemia. So we got to look for hypoglycemia, check your blood sugars. Even all stroke patients get a blood glucose check every time. Right, your postictal state. Again, this is after the seizure. How long? And this can last 45 minutes to an hour for their postictal. Or a subdural epidural bleed, which we talked about those already. And again, here's some more here. The epidural versus subdural. Right, so again, trauma to the head may result in intracranial bleeding. Bleeding outside the dura and under the skull, called epidural bleeding. Bleeding beneath the dura, right? But outside the brain is called a subdural. All right. So we see our epidural hematomas that are here. Kind of what I just showed you before. Right. This is actually not correct right here, though. This is actually a subdural. So what I'm going to do is I'm going to make this a little bit bigger and get really close. Right. You see the blue line? It goes around here. That's your dura. Okay, the blue line there. So if it's on the outside of the dura, you can see how this is being pushed. Okay, if you guys can see the hand that's on there, it's being pushed. These are ventricles here, where that line drops down. If you draw a straight line straight up and down here, that's your midline between your two hemispheres. Right, this is pushing pressure. Right. These are like I said, mixed martial arts stuff, things like that, kicks to the head, falls. Okay, your middle meningeal artery I talked about before, the fracture line. You have a fracture to the skull, causes your artery to sever, causing a bleed like you're seeing in the epidural hematoma. That's there. If I go down here again, I don't know why they made this picture with epidural. This is actually a subdural. So you see the dura is still in place. There's no pressure pushing up against it, but you have that concave, that moon-like. All right. Now, if you were to draw a straight line up and down from here, you'll notice the ventricles are all shifting. They're shifting like this because there's so much pressure on the brain. We're shifting those ventricles over. And by that, we're seeing a subdural hematoma with midline shift. And if you do a CT, they're going to give you like how many centimeters it is of that shift. The more we shift, and looking down a little bit farther, let me just bring this back so I get my pen back. All right. Oh, that's not it. There we go. All right. Your brainstem and your foramen magnum is that white spot that you see there going straight down. Your brainstem is here. If we're putting all that pressure, I should probably do the bottom one. Sorry about that. All right. Your brainstem being here, all that pressure pushing these ventricles out of the way can cause this to herniate, therefore losing our ability to breathe, being one of them, right? So we got to look at that kind of stuff. And again, be prepared for it, right? Significant trauma can cause subdural bleeds, can cause epidural bleeds. And if you have a subarachnoid, it's going to be even down deeper in this section like in here. And usually looks like, not be the greatest to draw this, but it looks like a star, almost like this. And what you'll see is like that down there, and you'll be able to see that star burst. Well, that's actually a better term for it, is you'll see that star burst on the CT, and that'll be more of your subarachnoid, your subarachnoid bleed. So hopefully I didn't confuse anybody on those. The big ones to take home are the epidural, okay, being up here. Again, it's above the dura mater. Your subdural being below the dura mater. The subdurals are actually really bad, as remember, they can push and shift your ventricles and cause a higher chance of brainstem herniation. All right, hopefully that was good enough for you guys there. Again, if you have any questions, please feel free to unmute. Let's let me know. I can go over those a little bit more. All right, so seizures. A seizure is a neurological episode caused by a surgical electrical activity in the brain. In the United States, it's estimated that 3.5 million people have epilepsy. Right? Seizures are classified into two basic groups. We have generalized and partial or focal. Let's go over those. Generalized are the tonic-clonic seizure. Okay, I call this flopping like a fish, right, out of water. Right, results from an abnormal electrical discharge from large areas of the brain, usually involving both hemispheres. typically characterized by unconsciousness and a generalized severe twitching of all muscles that lasts several minutes or longer. When we're doing our assessments for patients that have seizures, when did it start? How long did it last? And did they have another one that happened directly after? Right? That's our status epilepticus patient. And those are the really, really sick ones, right? That stop and seize and then seize again and stop and seize again and stop and seize again, right? Or I see patients at head trauma facilities, right? So those patients that go to rehab, they like a head trauma facility that's there, right? And they'll seize for half an hour, and that's normal for them, right? We still need to stop that seizure, right? And the only way we can stop the seizure is by giving a sedative like a benzodiazepine, right? Benzodiazepines, and that'd be like Valium, Versed, Ativan, things like that. Those benzos that can help stop that seizure, relaxing everything. But there's also other medications like Keppra being another one too, but we do not administer that in the field. So if you have a patient having a seizure, get a paramedic to you guys right away, right? Even if they're not seizing, if they seize again, we need to start giving them medication. And one of the most biggest ones that we carry on the trucks is going to be Versed, right? Midazolam, right? Valium being one of the ones you'll see more at home. A lot of times you'll see rectal diastat or diazepam is the name for it. So we're talking about trade name and trade names and generic names. So let's kind of go over those really quick. Valium is diazepam, otherwise known as Diastat. Okay. Midazolam is Versed. Okay. And lorazepam is Ativan. Okay. What you're going to see at home, a lot of times, typically for the pediatric realm, is they'll have Diastat, and the mother will do that rectal administration. You want to know how much it was and when it was given. Okay. So make sure you get that information from the house or from the family. All right, absent seizures do not involve any changes in motor activity, characterized by a brief lapse of consciousness, and where the patient seems to stare and not respond. Right, they get that blank stare. They're just like, you're like, "Hello, where are you? Right, where'd you go?" It could be an absent seizure. Right. On the partial or focal seizures, obviously, focal onset is a focal onset awareness seizure. There's no change in the patient's level of consciousness. However, patients may have numbness, weakness, dizziness, visual changes, or unusual smells and tastes. Right. They may also cause some twitching or brief paralysis as well. These are more your partial, your focal seizures. Right. Your focal onset impaired awareness seizure is the patient has an altered mental status and does not interact normally with his or her environment. Things just don't make sense when they're doing things. Results from an abnormal discharge of the temporal lobe of the brain, or other characteristics may be lip smacking, eye blinking, or isolated jerking. Patients may also experience unpleasant smells and visual hallucinations and exhibit uncontrollable fear or perform repetitive physical behavior. That could be them having that partial focal seizure, that impaired awareness seizure we're talking about. Right? Patients may experience a warning sign. It's called an aura prior to a seizure. They may say, okay, I'm getting that smell. I'm starting to say, okay, I'm going to seize. A lot of times, if they know this kind of stuff, this could include the visual changes or hallucinations. If they know it's coming, they may lay down on the floor just to prepare for the seizure to happen so they don't collapse from a standing height. People with a history of seizures recognize this and usually take steps to minimize the injury, like I mentioned before, they lay it down. Auras do not occur prior to every seizure, but not all patients with a seizure disorder experience an aura. So they might not. And if they could ask them, hey, did you experience an aura? Did you know this was coming? Generalized seizures are characterized by a sudden loss of consciousness, followed by a chaotic muscle movement and tone and apnea. Right. Let's see. Many exhibit bilateral muscle movements characterized by a cycle of muscle rigidity and then relaxation. Typically lasts less than 5 minutes, followed by a post-ictal state. We need to pay attention though. Okay, if it's lasting more than 5 minutes, it could be status epilepticus, which means this is a very critical patient, right? Or they have one that lasts less than 5 minutes, but then they have another one right after that, right after. There's another seizure that happens. right? So look for those different signs that are there. We need to know how long they were seizing for. Rough estimate, right? An absence, or what they used to call a petit mal seizure back in the day, seizures that last just for seconds, after which the patient fully recovers with only a brief lapse of memory of the event. Okay, those are your absent seizures. Your status epilepticus or seizures lasting more than 5 minutes and are likely to progress to status epilepticus. Seizures that continue every few minutes without a person regaining consciousness or last longer than 30 minutes. Recurring or prolonged seizures should be considered immediate life-threatening situations. Keep in mind that when a patient is seizing, they're not breathing, right? They can become apneic. They can become cyanotic. Their oxygen levels will start to drop. Right, so we got to make sure we're looking at this. And if you see this, you need to call for paramedic care because they need to start getting a benzodiazepine. Right, here's some other things. Here's some other common causes. Obviously, epileptic or congenital origin, structural, being like cancerous, benign tumor, an infection or brain abscess, scar tissue from an injury within the skull, head trauma, stroke. Right, um, metabolic issues like hypoxia, and they talk about abnormal blood chemical values. I'm going to go back to that here in a second, okay? Because we get those calls a lot. Hypoglycemia, poisoning, drug overdose, sudden withdrawals from alcohol or medications, and febrile, that's sudden high fever, in primarily in children. I'm going to, again, I promise I'm going to go back to that blood chemical value thing. Right? Sudden high fever does not mean that they have a temp of 104. Right? That means that in a very short period of time, they went from being normotensive, normothermic. So again, 98.6, 99 degrees to 104, 103, very fast. There's a fast increase in that body temperature. And the body says, whoa, wait a minute. We need to start seizing to cool the body down. That's why when you get called for an emergency call for a pediatric seizure, and you get there and you talk to moms that says, well, the baby seems fine now, right? Did the baby have a fever? Yes. Right. And if the fever was there, right? Was it treated? Did they get any Tylenol administration at all? You need to make sure you're asking those questions. Now, let's circle back to abnormal blood chemical values. I've seen numerous amount of times where EMS gets called. They say you're a paramedic level ambulance, paramedic basic, PB truck, and you get to the scene for the abnormal lab, and they go, "This is BLS. Here, you take it in." It's just abnormal labs. They'll be fine until we get to the hospital, right? That's not a correct answer, right? One of them being sodium, right? Our normal sodium levels are 135 to 155 normal sodium levels. If the patient has a sodium level of 115, 120, the potential of them having a seizure is very high. Okay, those are ALS calls. We'll get into other lab value stuff later, but the big one though is your hyponatremia. So hyponatremia, low sodium. So they say my sodium level is 115, that needs to go paramedic level. And the EMTs, you guys should be saying, no, I don't feel comfortable taking this. That can cause seizures. And I don't need a seizure happening in the back of the ambulance with you driving. You should be out back to treat it faster. Right. And on top of that, they need an IV, and they should be getting sodium chloride as an administration of fluid to hopefully bring their sodium levels back up a little bit higher. Right. So again, that's an ALS call. And also need to be in a cardiac monitor. Again, I'm not going to get into paramedic monitoring, but there are going to be different changes in your PQRS and T complexes, your heartbeat complexes on a 12 lead. Right. So again, other things you should be looking for. Epileptic seizures can be controlled by medications: Keppra, Dilantin, phenobarbital, Tegretol, Depakote, Topamax, Klonopin, all these different medications. So when you're looking at your medication list, okay, as you get from your patient, they have a list, they tell you, and again, you don't know much about their history. If you see these medications on there, it's going to be because they have seizure control being done. Right. So those are kind of lists of medications that are used to treat seizures. Right. The most important of recognizing seizures is recognize when a seizure is occurring and whether the episode differs from previous ones. If they had partial, those petit mal, or again, absent seizures, now they're doing full-blown tonic-clonic movements, right? We need to document and note that. Recognize postictal state and complications of the seizure itself too. So once they go into that postictal state, right, do that assessment. Okay, your head to toe, look at the tongue, look at the airway. Is there any blood? Do you do any suctioning? Right? How does the heart rate feel? It's probably going to be pretty tachycardic coming off a seizure, right? Do a full body assessment, palpate the abdomen, listen to lung sounds, right? Did they cause another injury because they were seizing? Right? Get them on oxygen. And if you have end tidal monitoring, put them on the end tidal nasal cannula and let's watch their perfusion, their ventilation status, and their oxygenation. Okay. Pulse oximetry measures oxygenation, where end tidal CO2 measures ventilation and perfusion. They are two different things, but they work hand in hand. Right. So we got to make sure we're looking at both of those. Right. And then again, identify other problems associated with that seizure and maybe what may have caused that seizure. Right. After this, the postictal state, so once the seizure is stopped, the patient's muscles relax, becoming almost flaccid or floppy, and the breathing becomes very labored. This may also be characterized by hemiparesis, so that paralysis, or weakness on the one side of the body, resembling a stroke. Head bleeds, which are also strokes, can cause seizures based upon pressure in the brain. Thrombolytic, no, that's not thrombolytic, thrombus strokes or the occlusive stroke can also cause seizures due to hypoxia or lack of oxygen to that brain, can cause seizures. So was it a seizure? Was it a stroke causing a seizure, or is the seizure giving stroke-like symptoms that are going to resolve? Right, and also check your blood glucose. Hypoglycemia can also cause seizures as well. If the patient's condition does not improve, you should consider other possible underlying conditions. You have to look. You have to do your assessment. You got to do your head to toe and do the best you can with that postictal state. Part of your assessment is also interviewing others to find out what exactly happened. If there's anybody else around, right, you got to put on your detective hat and say, hey, what's going on with this, right? Are they having seizures because they decided to stop drinking alcohol cold turkey? Now they're having DTs, right? So get all that information. Syncope. Seizures are often mistaken for syncope or fainting. Fainting typically occurs when the patient is standing. Seizures may also occur in any position, and fainting is not associated with a postictal state. You need to pay attention to syncope. Syncope can be caused by a lot of different things. Heart attacks, right, is one of them. Pulmonary embolus is another one. Okay. So again, other things can cause syncope other than seizures or mistakenly caused like that. Altered mental status, aside from strokes or seizures, the most common type of neurologic emergency that you will encounter is a patient with an altered mental status. So what can cause that? Well, let's talk about that for a minute. Hypoglycemia, check your blood sugar. Hypoxemia, right? So low oxygen in the blood. We have pulse oximeters, and we can also look at the patient's skin color as well. Are they a cyanotic? Things like that. Intoxication can cause altered mental status. Delirium, drug overdose. And again, we'll do something on toxins another day. We'll do a toxins lecture. But there's a lot of different things we can look at under drug overdose, looking at toxidromes. So we'll cover those in another class. Unrecognized head injury can also cause that as well. Brain infection, body temperature abnormalities, brain tumors, overdose and poisoning. Right? We look at all of that. So looking at our assessment, all right, we look at our scene size up, make an early determination whether the cause is medical or trauma. If it is trauma, again, we might need to put cervical collars on, backboarding, depending on what state you're in. Consider the need for spinal motion restriction and call for additional resources early. Right? Seizures are not something to mess around with. They need to have benzos. They have to have that sedative to control that, to break that seizure. Okay, so get them early. Do your head to toe. Your scene size up. What caused it? Was it a medical emergency that caused the accident, or the accident caused a medical emergency? Is it one or the other, or is it both? So you'll get that on your scene size up. Your primary assessment, look for any life-threatening conditions, ABCs, right? Airway, breathing, bleeding, circulation. If there's a major bleed, if you don't stop it, they're going to die. So again, you need to make sure you're stopping your bleed. And I know this is not a trauma class. Perform your rapid exam. Head to toe assessments on your rapid assessment should take no more than 60 to 90 seconds. That's why they call it rapid exam. That's your head to toe. And what you should be looking for on that primary assessment, right? I'll get that here in a second, actually. Establish priorities based upon assessment of the patient's level of consciousness and your ABCs, okay? What I mean by head to toe. Head, ears, eyes, nose, throat, really quick. What do pupils look like, right? Is there any bleeding coming from the ears? Checking the eyes, again, pupils, nose, any blood, throat, you need a suction. No? Moving on to the next part. Looking at the neck. Tracheal deviation, JVD, two things to look for. Again, if they have tracheal deviation and then in your assessment really quick, that's a late sign of a pneumo. The patient's probably going to be dead by that point. Right, but look for that jugular vein distension. Probably the back of the neck, apply your cervical collar. Go to your chest. When you're at your chest, breathe in and out. Okay, hands spread open around the rib cages. You're feeling for any flail segment, good equal rise and fall. Quick listen to lung sounds. Does not have to be in depth. That's going to be on your more detailed assessment. Your primary, remember, is rapid and quick. You get to the abdomen, palpate once. Both hands across the abdomen one time. We're not trying to pinpoint exactly what could be going on. We're looking for, is there rigidity or not? Okay. If it's a potential trauma, pelvic exam by pushing in and down, no rocking, checking your legs, checking your arms, right? Decap BTLS, checking CSMs, uppers and lowers. Roll the patient on your board. If it's a trauma patient and you still use boards, you can roll them over, check the spine, put it back on the board. That should take no more than 90 seconds at most to do your head to toe. Get him into the ambulance. Get your baseline set of vitals in the back of the ambulance. Now we have time. We looked at our rapid. We identified life threats. Now we're moving on to our detailed assessment. We're going to try to get our sample history, OPQRST, all that wonderful stuff we have to do, right? And then we get our lung sounds and we do our reassessment every 5 or 15 minutes, depending on patient stability, right? History taking. If the patient is unresponsive, gather any history from family members or bystanders. Look for the medic alert bracelets. Okay. The unknown unconscious patient could be a diabetic. It could be a seizure. Who knows, right? Look for those medical alert bracelets if they're wearing them, and that gives you more of an idea of what's going on. If no one is around, look for explanations of the altered mental status. Right? If you see someone in a barn and they're unconscious on the floor, and you see hay being stacked on the second level, did they fall and hit their head, causing a seizure? Okay, so look around at everything we're doing, what they're doing, and make sure you have good scene situational awareness and what you're looking for. Look for signs and symptoms that may indicate that cause. Try to determine the events leading up to the incident and obtain your sample history. As far as vital signs go, patients with significant intracranial bleeding may have a great deal of pressure in the skull that is compressing the brain. Right? This slows the pulse and causes respirations to be erratic. Right? Blood pressure is usually high to compensate for poor perfusion in the brain. Unequal pupil size and reactivity indicate significant bleeding and pressure of the brain, and check a blood glucose. As far as your stroke assessment goes, and I have some other ones, we're going to go over a couple of different ones that are there. Stroke scales evaluate the face, arms, and speech, like the BFAST mnemonic. The Cincinnati pre-hospital stroke scale and the Los Angeles pre-hospital stroke screen are commonly used. Right? So we think about that 3-item stroke severity scale, Los Angeles motor scale, or Glasgow coma scale. As an EMT, you should be very familiar with your Cincinnati stroke scale or the race scores and things like that you guys do in South Carolina. And then for the New Hampshire folks that are on this same presentation, You guys are using your fast TD scores up there. But you should all know your Glasgow Coma scale. Remember that 3 is the lowest number you can get, 15 is the highest number that you can get. Right? Eye, verbal, motor are the 3 things that we're assessing. With eyes, it's 1 to 4. With verbal, it's 1 to 5. And with motor, it's 1 to 6. Okay? You need to have that stuff memorized. Right? And if you're transporting your trauma patients, let's say to Richland, they're going to ask you for a GCS score. Most hospitals do when you're calling. Right? So again, you need to make sure you're getting that information and to be able to understand that Glasgow Coma score. So right here is your BFAST stroke. And so balance, eyes, facial droop, arm drift. Ask patient to close eyes and hold both arms out. Speech and time. If you look at this as a whole, okay, you ready for this? Facial droop, arm drift, and speech is your Cincinnati stroke scale. Now we're just adding balance, eyes, and time. That's your BFAST. Right? So going to the next one here. Facial droop, arm drift, speech, like I mentioned before, that's your Cincinnati stroke scale, right? Have the patient show their teeth, have them smile. If one side drops, we have abnormal response, right? Arm drift, closed eyes, hold both arms with palms up in that palmar position. Arms up and see if one drops, right? Ask the patient to say, you can't teach an old dog new tricks. That allows the patient to use all of their facial muscles to see if one, can they get those words back out to you? And 2, is there are the words slurred? Or can the patient not speak at all? Right? Ask them to repeat it. If they can't, again, another abnormal response. This is your LA pre-hospital stroke screen. I have not seen this used much, at least not in the states that I have worked. We teach it as it is on the National Registry exam, potentially. And they ask you some questions about it. But again, I usually don't see this very often. If any of you that are listening right now currently have used this scale, just let me know. I don't use the LA stroke scale. I use the fast ED. Again, when I'm doing another interfacility, I'll do NIH only because that's a more in-depth stroke scale for me to utilize. But again, Cincinnati stroke scale and your race scores and all that, really good thing to utilize. Your 3-item stroke severity scale, level of consciousness, arm drift, and gaze. Right? Again, if it's greater than 4, indicates stroke is likely. So it's another scale you can utilize as well. All right. Any questions on those different scales? If not, I'll take silence as a good thing, and we'll move forward. All right. Then we'll have some quiz questions at the end to go over together. All right. So all patients, all the mental status should also have a GCS score calculated. And I mentioned before, this is your GCS score. All right. Spontaneous to none. Orientated conversation, confused. Dementia is confused. Dementia patients cannot have a GCS score of 15. They're going to have 14, right? If they make inappropriate words, it's a 3. Incomprehensible sounds is a 2. Then our best motor response. Obeys commands, localizes pressure 5, withdraws from pressure 4. Abnormal flexion, abnormal extension, right? These 2 here are bad. Those are really bad to have, okay? Flexion being flexing arms going in. That's your decordicate posturing, right? Decordicate posturing. Abnormal extension, when the arms flex back out again and they're extended, is called disarabate posturing. If you start seeing these 2 here and they have potential head bleed, most likely their brainstem is now herniated. Usually that indicates brainstem herniation. So it's something to think about. Okay. So if they got a 1, they're unresponsive, let's say a head bleed, right? Again, they're not talking to you or they're making sounds, right? So let's say they're not talking to us 2 and they have disarabate posturing, their GCS score is a 4. Okay. Look at those as a whole. And these are things you guys should have memorized. if not written down somewhere where you can easily access it. Focus on reassessing ABC, airway, breathing, circulation, or a tourniquet if there was a major bleed. Vital signs and interventions. We need to be getting vital signs every 15 minutes. Oh, I just saw that come up. I apologize. Go back to the chat. Let's see. So can you explain it more like hours, since it's extension to pain or flexion to pain? Okay, so what you're looking for, and I'm assuming you're talking about the race score, Crystal. You can unmute if you want. Okay, so what we're looking for as far as the pain goes is if we elicit a pain response, right? So again, that's your motor function and stuff too. It's kind of like both the same. Looking at that pain score, it's kind of hard to explain. I'm trying to figure out how to explain that for you. Let me just go back to that. Hold on a minute. Go back to the GCS score really quick. All right. So this is kind of following along with that race score that you're talking about. Okay. So that extension or flexion of pain, if you cause a pain response, for example, if I pinch your right shoulder, in theory, the left arm should come to the right shoulder to push you away, right? In theory, that's what should be happening. If they don't, and the arm doesn't move, they try or they go to the wrong shoulder, right? That would be more of the pain response. Or if you inflict pain on somebody, what would be the normal response? If you're not seeing that, or they start inflicting pain, they start going up to that boxer's position. Okay, that's really bad. That boxer position that you see, or the arms flexing, will actually bring back to that abnormal flexion we're talking about here in the GCS score. So it kind of goes hand in hand with that elicit of pain to see what kind of response you're going to get. Does that make sense?
Okay, it makes more sense because I've been confused on how, like, if we get like a discharge or like a 911 call, and it's just one of those where I'm like, these two very confusing to me right now.
Yeah, the biggest thing to look for, like those discharges, things like that, if you're not doing a race score and eliciting pain, if you find a patient that's, let's say, they're coming out of the, so you're doing an interfacility transport from ER to ER.
Yeah.
Okay. I'll use BBMC to Orangeburg. That's one of the ones I've done a lot of. Because again, you're the critical access hospital that can't admit to a hospital that can, or they go to Charleston from there, or whatever it may be, right? I'm reassessing this GCS score during transport, especially even if they're intubated or if they're unresponsive and we're transporting at paramedic level. I'm looking at this all the time because, again, if I start seeing, let's just say they're sedated but they're not paralyzed, and again I pinch them and they withdraw from that pressure, so they move their shoulder. Okay, I know that GCS score is probably about a 4, unless I have significant sedation on board where there's no movement at all. I want to make sure I'm reassessing this. I want to put this into the 911 perspective, might be a little bit easier to understand than interfacility. If you're responding to a 911 call and you find that patient on the ground and they're unconscious, we go, sir, can you hear me? Sternum rub, trapezius pinch works pretty well. And if they take and they move their hand, they try to slap your hand away from pinching them, right? That'd be more of a withdraws from pressure because they're pushing you away, or pretty close to localizing pressure if they can feel it, right? Even though they're giving you inappropriate words or again, eye opening into sound only. But when you start seeing that flexion kick in, there's brainstem herniation. There's something else going on neurologically that's causing them to flex up. And once they start flexing outward, 99% of the time they have brainstem herniation there. And now those are your really critical patients that should be flown. Is that a little bit better?
Yes, actually, it's a lot better.
Okay. I want to put in the 911 setting for you. It might be a little bit easier than interfacility. A lot of times in IFT, they already have those scores done for you, and it's more just a reassessment during transport versus finding and doing your initial assessment on what you're going to find.
So. Okay. Thank you.
You're welcome. All right. We're here. So emergency medical care. ED physicians determine if there is bleeding in the brain for patients with suspected stroke with a CT scan of the head. The initial scan, not a CTA, but a CT, is done with non-contrast. Okay, they do not put contrast into the brain. Right? CTAs are different. So in most patients with a suspected stroke, physicians in the emergency department need to determine that is there bleeding or not. Because if there is bleeding, they're not going to go with that thrombolytic, that clot buster they're talking about, thrombolytics like TPA, right? Because they don't want that to happen. They don't want to make it so that way it thins the blood out more, right? We don't want that to happen. So they have to do that initial CT to figure out, yes, there's a bleed, no, there's not. Right? If there is no bleeding, the patient may be a candidate for the blood clot dissolving medication, and that's that TPA that we were talking about. If bleeding is present, the medication will increase bleeding to disastrous consequences. I'm talking about significant bleeding in the brain where it gets worse and worse and worse. Right? There are a lot of side effects of TPA, and that's why before they give it, they have to be able to speak with the patient or family to make that decision, and they get all the pros and cons about TPA before it's administered. When I worked in the ER, we used to do telestroke all the time. So if EMS came in with a stroke patient, they would go directly to CT from the ambulance to CT directly, not even going into the ER, not to a bed, nothing, right to CT. While they're in CT, I would then have to bring up the neurologist from wherever they may be through the telesystem. They're on a screen and they can do the assessment with me standing next to the patient. Patient comes back from the CT. Those results then got sent to the neurologist for review. At that time, I'm literally talking with the neurologist through a television and camera systems, as well as the telestroke setup, and he's asking me to perform an NIH score right in front of him. Once we're done with that, the CT has been read. Last or normal time, if it's like say an hour or 2 hours, they're candidates for that TPA, right? As long as they're not currently on blood thinners and everything else, they're candidates for that TPA administration, right? And it's being done real time. And then they take that patient, and whether or not we have to intubate, put them on a ventilator, or we transfer them out to another facility that has that ability to do that thrombectomy or pull that clot out. So again, critical access hospitals like Bamberg, for example, or for the New Hampshire folks that work in the same system or for our presentations, things like Memorial Hospital or Huggins Hospital in New Hampshire, the critical access ones. Those small hospitals have those abilities to do those CTs, CTAs, administer TPA, have the teleconference with stroke centers and things like that. They have those abilities, okay, as part of the stroke system. Patients who have had a seizure requiring definitive evaluation and treatment in the hospital. For patients who are having a seizure, protect them from harm. Maintain a clear airway by suctioning, provide oxygen as quick as possible, and if the head or neck trauma is suspected, providing spinal mobilization. I am not a big fan of backboarding. And a lot of states have taken backboarding away. We no longer backboard patients for spinal immobilization. It is used for extrication purposes only, right? Again, follow your local protocols. I'm not telling you don't use them, right? What I'm saying is follow your protocols. Up north, every state that I've worked in have gotten rid of backboards. They're on the trucks for extrication only, and that is it. Once they get to the stretcher, we take them off the backboard and put them on the stretcher, and that's actually better for the patient. We also don't want them laying supine. They can lay at a 35-degree angle. Another thing also to mention with head bleeds, I should have brought that up earlier. If you're transporting a patient stroke or head bleed, let's say occlusive or hemorrhagic stroke, whatever one it may be, do not lay the patient flat and do not lay them sitting all the way up. 25 to 35 degrees is where they need to kind of be sitting. So raise the head up about 25 to 35 degrees, and that's where they're going to sit. Right. That way they're not going to be deficient of oxygen. And again, you're still able to perfuse, but also not causing too much blood to go to the brain itself. Right. So for patients who continue to have seizures and status epilepticus, suction the airway, provide positive pressure ventilations, quickly transport to the hospital, and rendezvous with ALS if possible. Again, if your closest ALS is the hospital, then document as such saying you called for ALS. There's no one in the area or available. Closest ALS available was the hospital itself. That way there, it kind of covers you through a CQI process. Headache should you should be concerned if the patient complains of a sudden onset of severe headache, and more severe in one spot versus others. Right. Again, those the worst headache of their life. Those are more of your subarachnoid bleeds. A sudden headache with a fever, seizures, or mental status following trauma. Those headaches with the fevers, these ones here, meningitis, right? Again, very contagious if it's viral, or sorry, if it's bacterial. Viral meningitis, not really contagious at all with other people, but that bacterial meningitis will be, right? We're not going to determine that in the field. There's other things that we can use to help determine that, different assessments, which I can get to another time we start doing medical emergencies. But if it's, again, protect yourself. And they have to do a spinal tap to confirm meningitis. Migraines, remember, always assess the patient for other signs and symptoms that might indicate a more serious condition. High flow oxygen intolerant. A lot of times, oxygen will help that patient, even if their SpO2 is 99%. Sometimes a little bit of extra oxygen and the high flow can help that patient relieve that migraine. For ALS providers, you can consider Toradol for pain management. A lot of times, NSAIDs will help you. Provide a darkened and quiet environment. So turn the lights off in the back of the ambulance, right? Do not transport lights and sirens. They don't want to hear that. They need to be in a dark spot. As far as stroke goes, support the ABCs and provide rapid transport to a stroke center. Maintain SpO2 level of at least 94%, but also don't go above 99. Okay. We don't want to have higher levels of oxygen in the system. And the only way to measure that is through an arterial blood gas. And they're going to look for something called a PaO2, which is the partial pressure of the arterial oxygen. And that's usually between like around 104, 105. We cannot measure that in the back of the ambulance. Our SpO2 stops at 100, and you can give more and more oxygen, and you just won't see it on readings, right? So 94 to 99% is pretty good. Routine use of oxygen therapy is not recommended unless the patient is experiencing respiratory distress or is showing signs of hypoxia. There's nothing wrong with you taking end-tidal nasal cannula and putting it on the patient to monitor ventilation and perfusion status. You don't have to run oxygen through it. It's there in case you need it. But honestly, any stroke patient I go to is going to get end-tidal nasal cannula, or if they're intubated, obviously they'll be on their mainstream. Fibrinolytic therapy and methods to mechanically remove the blood clot may reverse stroke symptoms and even stop the stroke if given within 3 hours. Those are the drugs, or 6 hours for mechanical methods. All right, there are some people now that are saying in some studies they have up to 24 hours now, depending on age of the patient, other things that are going on as far as the comorbidities that are there. If possible, transport to a designated stroke center. As far as seizures go, if the patient is in a postictal state upon your arrival, let them be in their postictal state. Okay. If they have a history of seizures and you get there and they're postictal and start waking up, they may not want to be transported. Again, go through your motions, give them the pros and cons of being transported, let them know the risks of refusal, and everything's signed off against medical advice or an AMA refusal. And protect the patient from harm, continue to treat and assess your ABCs. If the patient refuses transport or a seizure, contact online medical direction, ask them to speak to the patient directly. In some states, New Hampshire folks that are participating in this presentation, med control is actually part of your protocols. You got to contact medical control if the patient doesn't want to go. So that gives the doctor an opportunity to speak with that patient over the phone. Down here, again, it's based upon your medical directory you have and your protocols you have set within your own agency. Right? And to finish up, altered mental status, we got to figure out the cause, right? What is causing the altered mental status? Provide spinal motion restriction, airway, and ventilatory support if indicated, and transport to the appropriate facility. Don't hang up. I'm going to stop the recording now, and then we're going to go over the quiz, and then we'll do the roster at the end and answer any other questions.